introduce our distinguished panelists today. So first we have Dr. Feyi Hassan Oyewumi, who is a Vision Center Director for Eye Foundation Hospital in Nigeria. And Dr. Feyi is an ophthalmologist and clinical training at Warwick University in the UK. And she is a member of the Royal College of Surgeons in Edinburgh. And she's also a fellow of the College of Ophthalmology for Eastern, Southern, and Central Africa. So welcome to the program tonight, Dr. Feyi.
Thank you.
And so next we have joining us Dr. Robin Ross, who is joining us from Phoenix, Arizona. Dr. Ross is also a board certified ophthalmologist and the founder of Global Retina Institute in Arizona. She received that medical training from Weill Cornell University Medical Center. And in medical school, Dr. Robin actually was awarded a Scodars Fellowship to study in India. And that was where she really got her feet wet when it comes to helping people with eye problems. Her passion to prevent unnecessary suffering and disability has bonded her for life with many of our patients that reside in places like Liberia, Brazil, Ghana, Kenya, Nicaragua, Cambodia, and other countries in need. She is known as a change agent and absolutely a pioneer and a fearless disruptor. She took time out of our clinic day to join us today because it's in the middle of the day in Arizona right now. So Dr. Ross, thank you for joining us today.
Thank you for having me.
Absolutely. And finally, it's my honor to introduce my good friend, Dr. Matt Maltese, who is the founder executive director of Pennsylvania Pediatric Medical Device Consortium. This is an FDA-sponsored endeavor that was established in 2013 to spawn development of pediatric medical devices. He is an adjunct professor in the Department of Engineering at University of Pennsylvania, and he's also an associate fellow at CHOPS, Children's Hospital Center for Injury Research and Prevention. He is the Chief Innovation Officer at X Biomedical, a company that he co-founded to commercialize one of his many inventions. And this is an invention that is called a holographic stereoscopic microscopic technology, essentially a portable microscope that could be very useful in doing surgeries like cataract. He is a director and the treasurer of our foundation. And so Dr. Maltese, it's absolutely a pleasure to have you join us tonight as well.
Thank you for having me.
All right, so then we maybe go to our panelists. Maybe tell us a little bit more about yourself, if there's anything else you want to share, and your interest in addressing avoidable blindness. You know, why are you doing this? So maybe we can start with you, Dr. Ross, and then we can go to the rest of you.
You know, my interest has been since medical school when I had the first chance to see cataract surgery performed and see the impact on people. I think we all have to find something we're passionate about of making the world a better place for people, and I admire what you're doing. But we all have a call, and we have to know what that call is, because someday we'll go meet our maker, and we'll be asked, what did you do with the talents you had, with your finances, with your time? And I always knew that the visual aspect of making people see better and doing something that was going to impact their ability to read, learn, do everything was where my passion was. And the minute I picked up a indirect and looked into the retina, I knew that helping people see was going to be my path. And it's been a long path, but I always knew I had to give something back. So I practiced for 20 years outside of Flint, Michigan, and grew that practice and have always gone overseas to many countries. But when people see, whether it's from glasses or whether it's from cataract surgery, but my passion was always developing a process to teach people retina, because I knew that ultimately that would be a big cause of world blindness. And now we're in a myopia epidemic where people have very long eyes and they're very nearsighted. So we're approaching where we need lots of retina specialists and we don't have them. Most people don't realize that when you look at low and middle income countries, 9 out of 10 people that live in those countries have no access to surgical care. That means cataract surgery, glaucoma surgery, retinal surgery, cleft lip and palate, hearing. So tackling the ability to have access to surgery is a major problem. But the evidence base that for, in some places, $10 cataract surgery for small incision is so cost effective. And we have people, most people think of it as an aging process, but in many parts of the world, India, Nepal, we have people in their 30s that still have potentially 20, 30, 40 years of work that are blind. And so that phrase, the blind leading the blind, you'll see people who lead their family members with sticks. That's where that phrase comes to. But the good Lord told us to take care of the blind, the deaf, and the lame. And why were the blind at the top? We all have to answer that because it's such a huge impact and it's such a big area we can change. When I finished my training, there were 280 million blind in the world. Now we're at 1 billion. With the advent of technology and computers, we haven't made a dent. So we're all going to be held accountable for that large number of people. The first year that I went to Brazil, I had a request. There was a tribe going blind, and I thought it must be cataracts or some infectious disease. And we planned for a year to go on this trip. And just before the trip, a patient gave me glasses from Walmart. And I'm a surgeon, so I'm thinking, why are they giving me reading glasses from Walmart? My husband said, when God gives you something, you take it because you don't know what's on the other side. So we got down to Brazil and we had too much weight in our small planes. We had to lose weight overnight, but we still took those reading glasses and we landed in the middle of nowhere. And it turned out the whole tribe over 30 years had extended their lifespan from simple hand washing and umbilical cord care. And instead of dying under the age of 30, they were now living into their 40s and 50s. And their blindness was they couldn't see the baskets to weave and they couldn't see the fish to spear. They needed reading glasses. So I sent my husband all the way back to the small bush plane and he came with these Walmart glasses and they put them on and they thought they were a miracle because now they could see up close. And so the next year, the World Health Organization identified uncorrected refractive error as a major cause of blindness. And as I worked in Ebola for the last 5 years, from 2015 to 2020, I would be on the streets and people couldn't see their mobile phones. So women would actually put themselves at harm by asking people, what does this say? And somebody might rob them. So we don't think of needing reading glasses for safety too, but to learn, to read your Bible, to go to school for education. People need reading glasses. So something that's as simple as 50 cents could be a game changer. It could be a lifesaver because people everywhere across sub-Saharan Africa have a mobile phone. So, but if you can't see the numbers in the phone to dial correctly, you could put yourself in harm's way. So I think what Benson, what your nonprofit is doing is wonderful. My nonprofit's focused on training. So building a virtual eye hospital where we can bring surgeons and train them in a surgical simulator so that their skills are improved. Because we now recognize not everybody's as great as our colleague here in Nigeria doing surgery. If somebody operates in a community and causes blindness because their cataract outcomes aren't as great as Dr. Fahey, then people in the community don't come for care. So they're left blind because of fear. So what we have to do is improve in every aspect, access to cataract surgery, training, so that the cataract surgeons are the best of the best in Africa. That's where we really have to focus our energies.
That's wonderful. Thank you for sharing. I learned a lot just listening to you. So thank you. Maybe we'll go to you next, Dr. Fahey, and then we'll go to Matt.
Thank you, Dr. Ross. So I think for me, my passion for addressing avoidable blindness is really kind of started in childhood. My father started Eye Foundation Hospital. It'll be 30 years next year. And right from the beginning, he came back to Nigeria because he felt a call to come back home. He trained in the UK to come back home and to be able to give back to his community and to his country. And so he started up a hospital that was private and decided that it needed to be a private public mix. so that for those who could not afford. And one of our goals is that everyone should be able to access affordable eye care. And so Eye Foundation Hospital Group includes Eye Foundation Community Hospital. And as a kid, I went to outreaches and I went with them for surgeries in different locations. And I think I just really grew to love what was happening. And so when I trained in the UK and I worked in the NHS, I had satisfaction from my job, but I knew that there was a need back home. And so I moved back to Nigeria, and I'm now the director of the Vision Center program, which looks after our outreaches and our primary eye care centers. And that's my passion, because I want to be able to give care to those who cannot afford it, or maybe they can afford some care, but it's really expensive, and we can give them subsidized care. And I find it very rewarding, and feeling like I'm able to help those who maybe couldn't help themselves.
That's great. Thank you. Dr. Martis?
Great to be with you all. Thank you for having me. I'm a doctor, but I'm not a medical doctor. I'm an engineer and a bioengineer. And so my ability to help patients who have eye problems is not to putting my hands on them, but I work with the technology, the medical devices that the physicians use to treat patients. I spent my entire career in Pennsylvania at a children's hospital, working side by side with doctors, working on tough medical problems that are unsolved in high-income countries, where science and medicine meet, and trying to bring those things together to solve problems and cure disease. And as I was doing that, I got to know some eye surgeons at the hospital, and we started talking about children who go blind in low-income countries, and to learn that there's a need to develop technology to help the surgeons do the work. And one thing that we just got started with now is developing portable surgical microscopes that can be used by cataract surgeons everywhere. They can take it with them on an airplane. They can take it with the back of a Jeep. And they're much less costly and much more durable and portable than the current surgical microscope. So that's what I'm working on now, and I'm glad to be here with you.
That's great, Dr. Martis. Maybe let's stay with you for just a little bit, because I know that, to your point, one of the root causes of blindness in places like Africa, it's really lack of access to care, right? So what your organization has done, X Biomedical, it's the development of this device that can potentially help put a dent to this problem, right? And that's something I'm really excited about, because imagine being able to go to a remote part of Africa and do cataract surgery, which people aren't able to do now. Can you tell us a little bit about this device, and how do you see it maybe playing a role in the fight against avoidable blindness in places like Africa in the near future?
Sure. So eye surgeons and all kinds of surgeons who have to see things that are small use the surgical microscope. So eye surgeons, neurosurgeons, some types of dentists, microvascular surgeons, they use large surgical microscopes that are 7 feet tall, 750 pounds. Sometimes it can be as much as $1 million if you want to buy one, but they're at least $250,000. And these barriers, their size, their fragility, and their cost has put them out of reach of widespread use in low-income countries. They're ubiquitous here in the States or in Europe, but they're just not found they're not found as frequently as needed in these low-income countries. And so what we did when I was at Children's Hospital, we said, well, look, we've got these cell phones that have usually 3 cameras on them. They're quite small themselves. They're doctors have to see in 3 dimensions when they do surgery. So we have to be able to show them a 3D image. So that's a challenge in itself. I won't talk too much about how we do that, but what we thought we could do was we could take the technology that was used in these very, very large and expensive scopes and just shrink it down and take advantage of microprocessors and CMOS sensors and OLED projectors that are used in our everyday handheld electronic devices to make this much smaller, make it more portable, to allow Dr. Ross or Dr. Fahy to go anywhere they want to treat a patient and carry it with them every tool that they need to do that. Our company, incidentally, was funded heavily by the Department of Defense that had a large eye injury problem themselves in the military, and they couldn't get the microscope to the front line where the soldiers were being injured, and so the military also has a large humanitarian effort as well. They go to many countries to do mission work, and so they were very generous to us to help get our company started. But that's our passion. We're engineers. We can't touch patients, but we can help the people who touch the patients and make their jobs easier and more effective.
That's wonderful, and that's something I'm really excited about. I know that one of the reasons why you were so passionate about the work we do and wanted to be part of it from a board of directors point of view is also helping us to think strategically about the future path. And as things evolve and develop, how do we leverage technologies like this to really kind of help, expand care? That's a big part of it. The other part of this problem, as you all know, it's the variability between countries when it comes to eye care literacy. Also, when you look at availability of ophthalmologists and also, eye care services, the variability, it's like night and day when it comes to developing countries and countries in the West. So maybe Dr. Fahy, maybe we can start with you, and then Dr. Ross, if you want to add to that as well. What do you think about these inequalities in care? Can you maybe help us understand how much of an inequality we're talking about here between the communities that are underserved and the West, and how's that really impacting things for patients that otherwise need help and they don't have it?
Thank you, Benson. So from my experience, it's a huge difference between the West and what I see in Nigeria. I mean, I think one of the slides you had put up earlier says, there's kind of like an 8 times difference. What I do see in Nigeria is that there is a lack of access to care. So this could be because there aren't enough ophthalmologists, well-trained ophthalmologists. It can be because of financing. So a lot of people cannot afford care. But it's also because of lack of awareness. So a lot of people are not aware of certain conditions, things like cataracts or glaucoma, which are big causes of blindness, even refractive errors. And there's also a bit of myth about things. So you'll see patients who will say things like, oh, well, if I wear glasses, it'll make my eyes weaker, or they're not, they don't want their kids to wear them because they're afraid that it's going to impact them later on in life, not realizing that it's impacting them right then. So, it's a lack of awareness and education. It's a lack of affordable care, poverty, as we've all stated, and also having enough professionals to provide that care to patients also.
Yeah, it's interesting. I was reading an article just this week that was saying that in Africa, you have 2 to 3 ophthalmologists to every 1 million people, right? If you compare that to what happens in the West, it's not even close. They also, when you look at historical rate, or what we call incidence of visual impairment. In a lot of literature, you see 1.22%, and Dr. Ross can probably back me on that. But I read an article this week that was published in British Journal of Ophthalmology, I believe it was. And they found that the incidence of visual impairment in Africa actually it's close to 10%. So that's 1 out of every 10 people have this problem. That is huge, right? So from the variability of care, and Dr. Ross, I know you were in Africa for 4 years, if I remember correctly. You left your very thriving career behind in academia, and you went there and you gave it all. You know, what can you add to these particular topic we're talking about, from the variability of care and how this really impact people on the ground?
Years ago, I heard a global speaker who put this in perspective. You know, you look at sub-Saharan Africa, it's huge. I mean, we can't even drive across it easily. But when you look at the size of it, and the quote was, there are the same number of ophthalmologists in the San Francisco Bay Area as there are in the entire sub-Saharan Africa. Now that really rocked my boat and put it in perspective for me. San Francisco is a large million-sized city, but you take the total number of ophthalmologists and you scatter them across the large sub-Saharan Africa. That's enormous. So that in itself spoke of disparity. When I look at the disparity just within US healthcare, and we're a pretty privileged first world nation, you know, the studies are still coming out on disparity. With diabetic retinopathy, the 34% loss to follow-up is largely Hispanic, African American, and Native American, not getting consistent care because they're working every day. They can't go for monthly injections here in the US. And that leads to blindness because of lack of follow-up. When we look at women versus men here in the United States, a Stanford University study just showed that 34% less likelihood for women to get retinal detachment repair. That's my wheelhouse. So when I look at the fact that just within the United States, we have disparities, men and women, and Caucasian versus non-Caucasian. Now we're going to take it to places where 9 out of 10 don't even get surgery. So the disparity is highlighted by the fact that in first world countries, we have disparity. So the disparity must be enormous when we go to sub-Saharan Africa. Absolutely, and it is. And if you look at how it translates to dollars and cents too, right? The estimate is that it is enormous, it's ginormous from a financial burden point of view. There's an estimated annual global productivity loss of about $411 billion when you look at purchasing power parity. This figure far outweigh what it would actually cost to address the problem, right? You know, for 1 year, you can spend that money and essentially address the problem, which is about $25 billion will solve this problem. When I first started, Benson, when I first started for the short time that I was in Africa, in Liberia, post the Ebola response, the reason that I was impassioned to do that is at the time of Ebola, there was not a single trained ophthalmologist who could perform cataract surgery in all of Liberia. That was heartbreaking to me because you'd had civil war for 14 years. All the infrastructure had been destroyed. That means your capability of owning any slit lamp or surgical equipment was gone. And so your surgical skills were now antiquated. And now you had an epidemic. And now we said, gosh, you know, 25% of Ebola survivors have advanced cataracts from uveitis, but nobody in the whole West Africa was trained. So there was a huge capacity building issue. And even over the 5 years that we partnered with our Liberian partners to try to get training up, still wasn't to the capability that they could start doing cataract surgery. But many NGOs came in and started giving microscopes. But that training gap is huge. We have to train in a methodical fashion. And that's where I see big gaps. And you know, to train one ophthalmologist, it's not like an overnight procedure. Many people who are trained as cataract surgeons who don't have medical school background have better technique, than someone who may have gone to medical school who doesn't have the surgical capability yet. So that capacity building is a must, and it has to start. And it's not a 1 year or one trip that I make to Africa that makes you a great surgeon. It requires really working with somebody trained like Dr. Fahey. And she would have to work with them a long time to get their surgical skill up to her surgical capabilities.
Yep, no, it's a good point. And I had a little meeting with Dr. Fahey earlier today, and we were having this same conversation about training and how what they do in their practice and how, our partnership can extend to doing something like that in the near future. You're absolutely right. It's a very significant need, and I'm glad that your foundation is actually focused on doing that because it's a need that is not even tapped at all. I want to maybe, as we wind down the discussion, and I want to maybe talk a little bit about what role we can play as individuals. And this is important because when you think about government in Africa and all these other developing countries, a lot of them they don't do much for the people. There's no universal health care. Most of the countries don't have insurance coverage. A lot of people are so poor that they don't even know where the next meal is going to come from, talk less of paying for care, right? You saw those two patients. So in a way, I'm thinking, we know the government is supposed to be socially responsible, but we know in developing countries, in places like Africa, they don't. So what role can we play as individuals? So maybe that's a question to you, Dr. Fahey, because you and your team, you have boots on the ground. You're touching, you're feeling, you're doing this every day. When you look at our audience tonight and they're wondering, what can I do? How can I help? What role do you think we could be playing as individuals?
Well, I think, Benson, it's the role that you're currently playing. So, you started this foundation in 2021, and we partnered with you. I believe it was summer 2021 that we first started, and it was a trial, right? It was to see what could be done. And for us, we've been consistently providing these types of cataract services and primary eye care services in rural communities or communities that are underserved. But obviously, the more funding that you have to be able to do that, the more people you can reach. And so I think it is, for people in the West or who are listening to this program, it is by supporting foundations such as yours or, Dr. Ross or anyone else who is interested in really impacting this burden of avoidable blindness. And unfortunately, it would be wonderful if governments were interested. I can only speak as towards the Nigerian government. But if our public institutions were well funded, there was good maintenance of their equipment, and there was a national health service that could actually provide care free or at an affordable cost, that would be ideal. But unfortunately, that isn't the case. And so it is up to committed individuals and institutions to do that. And that can be helped by funding organizations such as yours to help those individuals or institutions who are committed to that.
That is wonderful to hear. And I think that's why what we're doing tonight is so important. We set a goal to raise $20,000, but $20,000 really is nothing, right? But it was meant to be a realistic goal, right? That we can, at the end of this exercise, we can say, we hit it. But the need is far greater than that. So if you're in the audience tonight and you feel like you want to be part of this solution, don't be restricted by the 20,000 number that we put, right? It's significantly more need than that. And I'm glad that you were able to say that. That's very helpful. I want to wrap the conversation tonight. I think it's been just marvelous to have all four of you. It took an act of Congress to bring you all together, given your respective schedules. Dr. Ross, like I said, this is the middle of clinic for her. She took time out of that. Matt is in Germany as we speak. So it's probably almost 1 a.m. there. Dr. Fahey is calling from Nigeria, which is very late there as well. So I can't thank you enough for your commitment, taking the time to join us. I want to invite each one of you, if you have some final comment about the topic tonight, as we wrap things up. So maybe we can start with you, Matt, and then just go around the table, and then we'll take it from there. Matt?
It's been a pleasure to be with you all. And one thing I want to highlight that you said earlier, Benson, in your monologue was about creating a sustainable plan, right? Where you're working with infrastructure within the company, in the country, boots on the ground, as you put it. And I think that's so important. If we're going to devote resources to this, that we do it in a way that's smart and wise and scalable. So thanks for adding that to to our mission.
Thank you. Dr. Fahey?
Thank you for the opportunity to be here tonight and for all that your organization is doing. I think if there's something that we share, it is a passion for helping those in need who, aren't able to help themselves and getting them to a point where they can go about their daily activities and contribute to their families and help bringing themselves out of poverty in a lot of cases. And that is definitely something that can be accomplished by helping them eliminate avoidable blindness. And I'm grateful for the opportunity to be here today. And I'm grateful for all that everyone is doing on this panel to try and make that happen.
That's wonderful. Thank you, Dr. Fahey. Dr. Ross?
What I wanted to say was that we did an actual economic return model for Africa based on income, and that training one cataract surgeon to operate for 10 years based on the normal economics of what people make would return 76 million, like $232,000 to the community by getting people sight so they could return to work and not keeping a person home taking care of a blind person. So most of us don't realize how impactful that is. Even in some place like Scottsdale, Arizona, 76 million is still a lot of money that you're generating for your local economy. So you move that money to a village or community anywhere in sub-Saharan Africa, that's a lot of money going back into the community. So the only way people go from low income to middle income is to generate businesses, to generate income for their families. And that's the only way. So cataract surgery is a great way to do that. So donating to Benson's Foundation, if there are any billionaires out there, this is a great way to make an impact. I know Mackenzie Scott just donated 15 million to Vision Spring, which is where we get our reading glasses, but it only takes one big donor. One billionaire donating $1,000 is like me donating $100. So we need to see that money flowing, and we need to believe that God will provide that provision for us.
That's wonderful. So in that note, I just want to say thank you to all three of you for making the time to join us today. It takes a village to save a village, and each and every one of you are doing your part, and I cannot thank you enough.